Our next section is myocardial and pericardial diseases. Now, myocardial diseases means cardiomyopathies, and cardiomyopathies can be either hypertrophic. Now, hypertrophic means you have a high ejection fraction. Hypertrophic cardiomyopathy means that you have a high ejection fraction. Hypertrophic cardiomyopathy means that you have a high ejection fraction. You can contract, but you can't relax. Dilated means you have a low ejection fraction. You can relax, but you can't contract. This can contract, but can't relax. This can relax, but can't contract. Restrictive can't do anything. It just lies there. Restrictive cardiomyopathy can't do anything. Just doesn't fill at all. Hypertrophic cardiomyopathy, the most common cause of which is hypertension. Hypertrophic obstructive cardiomyopathy, that's a different story. Hypertrophic obstructive cardiomyopathy means that you can present with syncope and sudden death if it's obstructive cardiomyopathy. Your mission about restrictive cardiomyopathy is just to know what things freeze or hold the ventricle in stasis, non-moving. Now, dilated cardiomyopathy. Decreased contractility. That's the same thing as saying low ejection fraction. Decreased contractility, low ejection fraction. Dilated cardiomyopathy is usually the left, but can be both. If the left dilates, it dilates the right later on. Now, dilated cardiomyopathy is the most common indication for a heart transplant, but the most common reason for it is ischemia. Ischemia causing a person to have dilated cardiomyopathy. Why does it dilate? Ischemia. Why does it dilate? I don't know. Ischemia. Alcohol does it as well. So when you have a person who's given birth and they have peripartum cardiomyopathy, we don't know what causes it. We know a small number of women make antigens that the antibodies attack their heart and you get a dilated cardiomyopathy. Why is it? I don't know. It's just the way it is. Now, drugs can cause a dilated cardiomyopathy. But the other thing is, whether it's Chagas disease or alcohol or adriamycin, or whether you're a cobalt-inducing adriamycin junkie who's just given birth and you're an alcoholic baby, the answer is all the same. I'm short of breath, paroxysmal dyspnea, echocardiogram, give me an ACE inhibitor and a beta blocker. What's the only difference between a dilated cardiomyopathy that's idiopathic and an ischemic one? Aspirin to fix the coronaries. Which is better for you, alcoholic cardiomyopathy or ischemic? Ischemic, because I could take you to the operating room and fix your ischemia in 4 hours, but I can't fix your alcoholism. I can bypass your coronaries without your consent, but I can't bypass your alcoholism without consent. Now, dilated thick cardiomyopathy. You know, these pictures always make me hungry. I just keep thinking what that would be doing with a little vinegar, breaded up, fried maybe a little bit. Tasty. Now, that is a big dilated chamber. That's what we meant by left ventricular end systolic diameter. At the end of systole, how much can it empty? The end of systole, how much can it empty? The end of systole, how much can it empty? The wall has become thin as the chamber dilates. The wall has become thin as the chamber dilates. The wall has become thin as the chamber dilates. So, subendocardial fibrosis. Subendocardial fibrosis means the walls become thin as the chamber dilates. And it can become fibrotic as well. It just means it doesn't contract so well. This is a picture of congestive failure. That's extravasculature. That's congestive failure, and that's extravasculature. It looks similar to the picture we did under congestive failure. You know why it looks similar to the picture we did in congestive failure? Because it's the same picture. That's why it looks similar. Oh, you know why it's the same picture? It's the same disease. We do it twice, though, because it's such an important disease. Okay. Look at that. Oh, let me see those spins again. Let's try those again. Wow. Let's do that again for the spin. Congestion. Whoa, what's that? Hey, where are the pulmonary arteries? There they are. Is that a heart big? Oh, your heart is so big. Oh, there's more room in a broken heart. Ah, Carly Simon. There it is. It's hip to be miserable when you're young and intellectual. Okay. Oh, look at those pulmonary arteries. Yes, there they are. Huge, aren't they? Yep, that's it. This person needs a diuretic. They need an ACE inhibitor. They need a beta blocker. But they need ACE and beta blocker and spironolactone more because they lower mortality. ACE, beta, ACE, beta, ACE, beta, spironolactone. So what is the difference between a Chagas disease, Adriamycin, post-myocarditis, viral cardiomyopathy, and coronary disease one? Aspirin and the ability to do bypass. Remember, it's better to be having ischemic disease. You can do more to fix it. Hypertrophic obstructive cardiomyopathy. What is the most common presentation? It's not sudden death. The most common presentation is regular old-fashioned shortness of breath. Oh, well, that's not very exciting. Regular old-fashioned shortness of breath. That's not very exciting. I know. Ready? It's much more dramatic to say, reporting to you today from Madison Square Garden. Dribble, 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 shoot, score, die. Well, it's a lot more dramatic than saying, reporting to you from the Staples Arena. A man became short of breath while running today. Wow, selection bias. It's selection bias. Sudden death seems to be the most common, but it's not. It's, remember, hypertrophic obstructive cardiomyopathy, genetic. Hypertrophic obstructive, genetic. Hypertrophic cardiomyopathy, hypertension. Remember, you get hypertrophic and it makes you short of breath. Short of breath. When you have beta agonist in tachycardia, the ventricular chamber size gets smaller. See, this is the ventricle trying to empty. This is the extra hypertrophic piece of meat on the side of that ventricle. Asymmetric septal hypertrophy, the extra hypertrophic piece of meat on the side of that ventricle. Anything that makes the chamber smaller. Anything that makes the chamber smaller increases the obstruction. Chamber bigger decreases the obstruction. Digoxin empties more. Beta agonists go faster, empties more. Tachycardia. When does the ventricle fill? The ventricle fills during diastole. So you don't have enough time to fit. You don't have enough time to fit. You don't have enough time to fit. Tachycardia, I don't have enough time to fill the heart. All of these things here, every one of them, is a way of saying, can you list the things that cause the left ventricular chamber size to decrease in size? Tachycardia, decreased ventricular filling time. Beta agonists, increased emptying. Dehydration, hypovolemia, exercise, tachycardia, they're all saying empty left ventricle increases obstruction. Makes it worse. Puts me in a hearse. Oh, look at that. The number one thing for shortness of breath. The number one clinical manifestation is shortness of breath. You can get chest pain and syncope, and sudden death is the least common thing. Hey, why do we get an S4? We get an S4 because we have left ventricular hypertrophy. Get an S4. So, you see, when it says sudden death can be the first manifestation, it's definitely your last if you have it. But the thing is, can be does not mean the same thing as most common. Can be your first manifestation does not mean most common. All patients with hypertrophic cardiomyopathy will have left ventricular hypertrophy on the EKG. But the most accurate thing is the echo, showing the hypertrophy and the alteration in valve function. When you have hypertrophy like that, it actually pulls your mitral valve leaflet, sucks it up out of the way in the wrong way. That's what we mean by systolic anterior motion. In systole, the valve leaflet in the mitral valve gets pushed out of the way. Systolic anterior motion, SAM. Systolic anterior motion, or SAM. The treatment is beta blockers and other negative inotropes and things that slow the heart. If you have a negative inotrope, it decreases emptying. If you slow the heart rate, you increase filling. Let's go back to that slide that looked at what happens here. See these things? If you say the opposite, it's the treatments. If beta agonists precipitates it, beta blockers make it better. If tachycardia precipitates, bradycardia makes it better. If Valsalva or standing makes it worse, That means leg raise and squatting make it better. So that means that people with hypertrophic obstructive cardiomyopathy slow the heart rate. Disopyramide, what is that? Disopyramide is like an 8-track tape player or a black and white television. Is it still around? Yes. What do you think about people who would use an 8-track tape player? Well, you'd say, where have you been for the last 25 years? Disopyramide. Disopyramide is a class 1A antiarrhythmic. It's in the same class as quinidine and procainamide. But disopyramide is extremely negatively inotropic. It's very negatively inotropic. It's so negatively inotropic that it increases ventricular filling. Disopyramide. Restrictive cardiomyopathy, what do I need to know? I need to know that restrictive cardiomyopathy is something that is uncommon because sarcoid, uncommon. Amyloid, uncommon. Hemochromatosis, uncommon. Cancer and fibrosis, uncommon. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Yes, these are